Welcome to the BSc Nursing Education series on hypertension management. This video offers a comprehensive clinical overview for future healthcare professionals, focusing on understanding the quote, silent killer in cardiovascular health. We begin with the foundations and definitions of hypertension, starting with an introduction to the persistent elevation of blood pressure. Hypertension is a chronic condition defined by persistently elevated blood pressure in the systemic arteries, known as the silent killer. It is often asymptomatic but can lead to severe damage to vital organs if left undetected. Early detection and patient education are crucial roles for nursing professionals. Clinically, hypertension is defined by a systolic blood pressure of 140 millimeters of mercury or above, and/or a diastolic blood pressure of 90 millimeters of mercury or above. Diagnosis requires repeated measurements on separate occasions to confirm persistent elevation. The current classification guides diagnosis and management. Normal blood pressure is less than 120 over 80 millimeters of mercury. Elevated blood pressure falls between 120 and 129 systolic and less than 80 diastolic. Stage 1 hypertension is 130 to 139 systolic or 80 to 89 diastolic. Stage 2 hypertension is 140 or higher systolic or 90 or higher diastolic. There are three main types of hypertension. Primary or essential hypertension, with no identifiable medical cause, accounts for 90 to 95% of adult cases. Secondary hypertension is caused by underlying conditions. Malignant hypertension is a severe, rapid elevation associated with acute, life-threatening organ damage. A critical hormonal pathway for blood pressure regulation is the renin-angiotensin-aldosterone system, or RAAS. Decreased renal perfusion triggers renin release, leading to vasoconstriction and fluid retention, ultimately raising systemic pressure. Mechanisms of blood pressure elevation include increased cardiac output, which increases systemic pressure, sympathetic nervous system overstimulation, causing persistent vasoconstriction, and increased systemic vascular resistance through narrowing of arteries and arterioles. Modifiable risk factors include obesity, which increases cardiac workload, high salt intake, which promotes fluid retention, smoking and alcohol, which cause vascular damage, and stress and anxiety, which trigger sympathetic responses. Non-modifiable risk factors are family history and increasing age, as blood vessels lose elasticity. Diabetes mellitus involves metabolic changes and vascular damage. Gender is also a factor, with men at higher risk earlier, and postmenopausal women showing significant increases. Hypertension is often asymptomatic initially. Common signs when symptoms occur include occipital headache, dizziness or vertigo, blurred vision, and general fatigue. Severe manifestations can include shortness of breath, chest palpitations, nosebleeds, and altered mentation. Diagnostic evaluation involves a physical exam and comprehensive health history. Blood work checks for lipids, glucose, and renal function markers. Urine analysis looks for proteinuria. Specialized tests like an ECG and echo evaluate cardiac function and structure, while KFT assesses renal impairment. Chronic hypertension's cerebrovascular impact makes it the primary risk factor for stroke. Types include ischemic stroke from atherosclerosis blockage, hemorrhagic stroke from ruptured vessels, and hypertensive encephalopathy causing acute mental status changes. Cardiac complications of hypertension include myocardial infarction due to increased pressure leading to coronary artery disease. Heart failure is also common, as the heart muscle thickens and weakens from excessive workload. Lifestyle modifications are crucial for management. Nutritional management centers on the DASH diet, emphasizing low sodium intake of less than 2.3 grams per day, fiber-rich fruits and vegetables, and low-fat options like lean proteins and whole grains. Activity and behavioral changes are key to managing blood pressure. Aim for at least 150 minutes of moderate aerobic exercise weekly. Smoking cessation is vital, as nicotine immediately causes vasoconstriction and long-term vascular damage. Stress management through relaxation and adequate sleep reduces sympathetic drive. Pharmacological management involves common antihypertensive drug classes. Diuretics, like hydrochlorothiazide, reduce overall fluid volume. ACE inhibitors, such as enalapril, prevent vasoconstriction. Beta blockers, like atenolol, reduce heart rate and workload. CCBs, like amlodipine, relax vascular smooth muscle. Nursing interventions focus on monitoring with regular BP checks using the correct cuff size. Encourage adherence to drug regimens. Assess for complications like edema or shortness of breath. Finally, Provide psychological and social support. Patient education is essential. Teach self-monitoring of blood pressure at home. Emphasize regular clinical follow-ups and compliance, even when feeling well. Educate on emergency signs, such as chest pain or vision loss, that require immediate care. This concludes our overview of hypertension management. Effective nursing care is centered on early detection, proper treatment, and lifelong patient education. Here are the image sources used in the video for your reference. Additional image sources are listed on this slide. Remember to study hard and dedicate yourself to your learning goals. Thank you for watching this video.